Good afternoon, good morning, or good evening, wherever you are in the world. I'm so excited to introduce us to Steve and Isabel. Isabel is already bringing the most phenomenal energy to the space, and I'm in Boston area, and Boston area needs some Isabel energy. So, thank you for bringing that for us. I'm sure that you will walk away from this conversation understanding more about cancer care, understanding more about remedying medical mistrust, and understanding more about some of the leaders in these fields who are not only full of history about these challenges, but also are still trailblazing as we speak. And Isabel is phenomenal. She's a cancer survivor, but also a phenomenal leader in healthcare, in cancer care, and again in medical mistrust. What I'm most fascinated to share with you, and what I want you to take away most from Isabel, is that despite whatever Isabel has experienced in her life, as a cancer survivor and more, Isabel's decided to use these challenges to fuel her to make additional impact. Now, cliche statements, what that looks like is that she showed up in Latino communities and made sure that Latino people are a part of the new frontier for cancer care and for solving medical mistrust, because Black and Brown communities, as we know, have this history and experience with distrusting the medical system. And Isabel's been a phenomenal mediator between the healthcare system and the Latino community. We're going to get a chance to talk about a lot of that today. What I want you to know about Steve and what I want you to take away about Steve is that Steve has also had a very rich experience, resume, and history with cancer care and with medical care in general in this nation. Steve met with me and said, Ruquan, I don't know everything about your experience, but I know enough about it to know that I need to know more. Okay. And that was a phenomenal thing to say. And that's why we're here, because we want to know what's happening with medical mistrust, especially related to cancer care. So now Steve is heading Harbinger Health, where they are pioneering a product that hopefully will be able to detect cancer in patients sooner than the products on the market can do today. Now, Isabel has some mistrust maybe about that. Steve is happy to converse about that too. But I'm going to get us started so that you can hear the answers to some of these phenomenal questions. Isabel, can you tell me, considering your background, considering your history, particularly your lineage and history, I want to know how your ancestors and our parents led you to the work that you're doing now, how that history, how your family history has shaped how you show up in your current profession.
Straight to genetics. I like that. Thank you very much, Ruquan, and nice to see you, Dr. Hahn. It was really an excellent opportunity to have a chit chat about these issues because they're so critical. I think I came out of the womb an activist. My mom was very active in the community all of her life. And I also came out of the womb very curious as a child. I talked too much. Everybody told me, be quiet, Isabel. But my grandma noted the greatness. She said, you're either going to be a lawyer or a journalist. So I became a journalist. So it was there that I was able, I think, and I was a reader as a child. So it was there that I was able to really satisfy the need to know. I want to know why all the time. And so I got that satisfaction as a journalist, and I spent 43 years in television news. But in the middle of that, and I worked in Boston, and I worked in Chicago, and I spent most of my career here in the San Francisco Bay Area. But the value add of that, Steve, for me, was being in the field and talking to humans on the ground and looking at their lives and hearing their stories and understanding their despair, and then trying to translate that to the larger audience to try to have one, empathy, two, let's work on solutions together, and three, recognize that we all have something to give and to engage. And so, I'm lucky, Ruquan, in some senses that I had that exact background. You couldn't say that about the rest of my brothers and sisters. So that goes to show you genetics and nurture and nature. They do different things for all of us, right? But I really, I'm so thrilled because I've had a lifetime of learning, and I'm never afraid of that next step. You know, my mantra was the only failure is in not trying. And so when cancer came my way in 2000, I was 52 years old and I was diagnosed with stage 2A Hodgkin's lymphoma. I had two thoughts when the doctor told me. The first one was, okay, God, this isn't about dying. What's the point? And the second question was, I wonder if I should do a story. And so I turned the camera on myself, recognizing that, Steve, you might remember this back in 2000s, even in those years, it was still the big C. A lot of people were not really familiar with cancer and all of its horrific impacts. And I said, okay, as a journalist, sitting in that on that anchor table in San Francisco, I have a huge audience and I need to show them what it looks like and how people feel about it. And so that gave me that opportunity to start to inform. And then, of course, I looked around the infusion room and I said, where are all the Latinos? Do we not get cancer? And then, of course, as I asked those questions, of course, I learned, you know, the dark side of the issue. And that was seeing low income, Spanish speaking, immigrant, undocumented Latinos having perhaps the most challenges. And that's when I kind of felt that tug on my shoulder. Ysabel, this is why you're here. And, you know, Steve, it's not like I want to say God gave me cancer, but certainly he marked this pathway as part of my lived experience because it really gave me the basics to understand what cancer patients are going through. But then when I started and created a couple of local nonprofits specifically aimed at these particular populations is when I really, once again, back in the field, observed their experiences. And that's what I decided, this is what I have to fight for. And if I can solve, listen to me, if I can solve the issues, all of these basic systematic issues for the ones who have the least, then I think we can solve a lot of systematic issues for a lot of people. So that's all I'm doing, Steve. Just a small thing.
I mean, that is terrific. And, you know, when you speak about sort of your upbringing, your mother, and I think that's what it takes. It takes a sort of certainty around being able to make a change. And mine, of course, came from taking care of cancer patients for 30 years and sitting across the table from many, many people who face this challenge from all sorts of backgrounds. And, you know, the one thing I sort of learned from this is that a lot of us are pretty similar. Now, we might come from different backgrounds, but the fears, the concerns, the issues that arise, the family, it's really very similar. And recognizing that there's a lot more that binds us than tears us apart, but also understanding that people do face unique challenges. And it's one of those things that I hope that we can get to this conversation, because although we're focused at Harbinger Health on trying to find the answers to inexpensive, easily accessible cancer screening for everyone, and I agree with you, if we start with folks who typically don't have access, we'll be able to solve the problem for everybody, really. But then what's the next step when you find out that you might have cancer? And there are challenges there as well that we aren't necessarily equipped at Harbinger to solve. And I think those are the things that require a systematic approach to the problem. And the last thing I'll say is, you brought up before we started the issue of COVID, and COVID exposed all of the issues that we're talking about, made them more acute. They always existed, but just made them more acute in our mind. And it's a moral obligation for us to solve those.
There's a lesson learned, but unfortunately, I think that too many of us have hard heads and don't take away the lessons. And particularly, and now I'm going to throw some fire, Ruquan, I'm going to, challenge, because too many academic institutions are stuck on hierarchy, including the feds are stuck on hierarchy. And so to me, sometimes community knows best, but they don't have an MA, a PhD, an MD behind their name. And therefore, It's just an opinion, But in fact, during COVID particularly, we saw communities save themselves. We saw them go block by block, knock on doors, tell people, check in on their fears, give them the information, try to dispel the disinformation, or the fantasies and all of the wrong stories they'd heard. And I think that there was a learning, and I said to many a public health care system and many officials, did you see what we all did together? Did you see how we all approached it from our different powers, if you will, our different knowledge and our different abilities? And we really came together to solve something. Why does this not become a model for future pandemics, as well as for the way we work in community? Because this is my big frustration. To me right now, the system is there. It's not to serve the patient, it's to serve the system. So in other words, the patient is serving the system. And until you expand the community to be part of that system, it is the center of that system. And then you build answers around it. I don't think we're going to get to that equity we're talking about.
Ruquan, may I jump in?
Absolutely.
Amen, Ysabel. I think, and if we don't learn that lesson from COVID, shame on us, because it's very similar when you take care of a patient. When you go in the room and talk to somebody, you need to listen to what they're telling you, because they will tell you what is top of mind, and they will help you find the answer to what's going on medically in their lives. And you absolutely must have that ear to the ground and to listen and to ask questions and to be open-minded about it. And Ysabel, I left government, and I decided, where can I have the most impact? And I'm with you. My little bias is going to come out now. I did not go back to academia because I saw exactly what you said during COVID. And listen, there are a lot of great docs in academia, took great care of patients. But when you think about what helped us solve problems, it wasn't necessarily there. And I remember, particularly when we talked to representatives of the Latino community about multi-generational households, the spread of different age groups. I mean, it's a different problem there than it is in other places. So help us to solve that problem, because you're living it, we're not. I think that is spot on. And that is a terrific model. And I think the other thing is, when you engage a patient in cancer care and you make them a partner with you in their treatment, or they make you a partner as a doctor in their treatment, it goes so much better. You solve the problem so much better. You reduce side effects, and I think the outcomes are better. Same thing with pandemics and public health problems.
Well, I'm curious, Ysabel and Steve, I want to know, what have you seen in your experience, whether it's caring for patients or in your activism in the communities? What have you seen in terms of the world's reaction to the world's response? And really, when I say the world, I mean the leaders. I mean the university leaders, or I mean the hospital leaders. What has been their response to exactly what you guys are talking about in enveloping the community in the system and making sure that they are one?
Well, to be fair, I have been, since about 2008, have really embraced researchers and academics, and a lot of them are Latino, working in the cancer sphere, because I needed to know more about what was happening in the Latino community. So I would go to conferences looking for Latino leaders. And of course, it was small, but I eventually was able to establish a network of these folk that I could go to, but I also did research with them. And what I saw was how research operates from within academic institutions. And it was like, if you tried to do something different because you knew it worked in community, even though you were sitting there as an advisor, it was still difficult to move them off of that which they knew. They had been instructed this way. You know that, Steve, in medical school, this is the way you do it. Do not go rogue on us, right? But if you're going to work and be nimble, which was what I did as a journalist, to respond to the community. They're not supposed to respond to me. I'm supposed to respond to their circumstance. I'm supposed to go look for their story, not my story. And so having done this, of course, and because I love learning and I knew that I would learn from academia, I have engaged in a lot of research, but I still know that I'm pushing up against institutionalized ways of doing things I do know there's some change. I'm working with the University of New Mexico on that exact thing. How does the community-based organization and them as advisors with us, how does that change? And I said, one, you have to invest in them equally. So don't go out and get $1 million grant and give us $2.50 an hour. You have to invest in us equally, one, so we can be better partners, so we can build our capacity, so we can turn around, train our people. And imagine what you have. You have an extra workforce out there who now understands better about engagement in research, who can then go back to community and say, okay, folks, I know we've had some bad times here. I know things have happened at us. I know we haven't always felt in control, but this is what I'm seeing. There are good guys in the system. There's really opportunities for us to be part of the solution. We can have some power and agency within these systems. Yes, it's tough, but aren't we used to tough? That's why we're resilient peoples, I just think that we actually grow an extra arm, and then we start to make it patient-centric, right? We're suddenly in the middle of things, and we're helping push stuff around. But I've been called on the carpet, Steve, by the IRB, because I just wanted to do a Q&A with the community. What? You didn't run this by us? Well, the doc said it was okay. I was just going to ask people some questions. This was during COVID, and I was engaged with Stanford in a project. But I really, really wanted to ask the community some direct questions about how COVID was impacting them on multiple levels, including mental health. And I figured they might answer us because we were like them. We were Latino. We were asking them in Spanish, right? They were seeing people who cared and came to them with respect, respeto, and compassion. And these are, any community appreciates that, in whichever language. All communities appreciate that kind of communication. And so, but I kind of went afoul of IRB, so they had to pull me back in line, So I'm constantly kind of pushing up against IRB. But I don't disagree with the premise of do no harm, but I sometimes ask, does the IRB do harm? Do no harm.
It's a really good point you bring out, and without necessarily addressing the IRB question, I think the incentives aren't aligned like they should be. And in fact, going out and asking communities questions about solutions, the impact, et cetera, is the way we have to solve this. And I think, and I don't know, Ysabel and Ruquan, if you know about Montefiore, Albert Einstein, that's in the Bronx, they have done remarkable things with community-based healthcare to keep people out of the hospital, to treat folks closer to home, and frankly, to reduce the cost of care and improve outcomes, which is what we all want. We want plenty of money to be around for people to be taken care of and to have better outcomes. And they've done it through the community and community-based care. And so there is a model out there that works. I worry and I fear that because the incentives in academic medicine aren't aligned necessarily completely with where the patient's incentives are, that sometimes that mismatch gets in the way. So I hear what you're saying, and we need to work on it. No question about it.
Right.
Did you know 80% of cancer care is delivered in the community? It's not delivered at Memorial Sloan Kettering, MD Anderson, Moffitt Cancer Center, et cetera. And that's where we really have to get down and do the work that's necessary to treat people closer to home. I'm with you 100%.
So we have to triage care, really. But Ruquan, I need to apologize because there might be some folks in your audience who don't know what the heck is IRB. So it's an institutional review board. It sits in many academic institutions. It also can be a private company that does IRB reviews, but it reviews all of the research that people put forward, and to make sure that it's not going to harm patients. And it has multiple kinds of issues that it looks at. But there's been some pushback on IRBs lately because they seem like vested interest, right? They're basically reviewing their own institutions' research and academic researchers. So there's a question, but I think as long as we all understand and have guardrails, because I sit on an IRB, I sit on the All of Us Research IRB, and I started from the very beginning, Steve. I came out of I don't know if you were still at FDA at the time, but this was when was it? 2016? Yeah, 2018, something like that. And the first thing I said, one of the patient advocates on this IRB at the federal level was, are you going to do the website in Spanish right away? And they said, well, the plan was for about a year. And I said, did you not talk about inclusion? Do you not want people to feel that this is about them, all of us? Then I think, and luckily there were some very lovely, wonderful bioethicists and academics on that IRB. And the chair recognized right away, agreed, and turned the conversation into academic language that everybody could get. But we got it passed. We got it passed. So there's a language involved here too.
A translation, no
Yes.
question about it.
Yeah.
So, Ruquan, what Ysabel just brought up about IRBs also gets to the issue of mistrust of research, because in fact, it was research misconduct that led to the Belmont Commission, that led to the, I think, significant and appropriate proliferation of oversight of research to make sure that people had autonomy, that they gave informed consent, et cetera. So there's an inherent tension there between the speed and the ability to get research done quickly and effectively and ethically, with somebody needs to mind the store to make sure that folks who want to do bad aren't doing bad. And so it's a double-edged sword, but we talked before, Ruquan, about the Tuskegee Airmen that led to significant mistrust in communities of color. And, this is the result of it. And it's a good thing in general. The question that I think Ysabel is bringing up that I have some sympathy for, did the pendulum swing so far that it actually inhibits the ability to answer questions that help people quickly?
Exactly.
That's the question we have to ask ourselves. I don't have the answer, but.
Ruquan, what I was going to say was that I've actually said to IRBs, is it not time for us to re-review ourselves? Isn't it time to, we talk about privacy, and 9/10 of the community out there says, what privacy? They know they're giving up so much. So what exactly privacy do I want as a human for you to protect? Give me the option instead of determining for me, which sometimes I think limits, as you said, Steve, some of the what we allow the program to do. Re-review consent. It's way too long. Most people don't read it. Oh my God.
Oh, for sure. It's like 10 pages long, very technical. It's supposed to be an 8th grade language. Ruquan, I was on a panel, and I know that I'm talking too much, and I'm sorry. I was on a panel where they asked about AI and ML and privacy, artificial intelligence, machine learning, and privacy. And it's like Ysabel was there, a patient advocate who I adore, was sitting next to me, and she said, let me just tell you this right now. If you have my records and you send it to someone who has the chance of curing me of stage 4, whatever cancer it happened to be, you go right ahead. You don't need to wait 10 months to do that, because I don't have 10 months to do that. I'm paraphrasing what she said. But the bottom line is, one size fits all to the privacy issue doesn't work for people who are up against the wall with a serious life-threatening disease. So it's a very good example, Ysabel, that you give. And of course, we have to be very cognizant of privacy. But it's your medical records, not mine, right? So you should be able to decide.
Right. Well, I hope, Ruquan, you're going to have a conversation on AI, or we get some of that in later, because I have a few things to say. Beto, you go ahead and ask the question.
Well, if we were in person, I would have brought you some real flowers, but I'm going to give you your flowers here, because what you just modeled for everyone who's watching is exactly what the remedy to medical mistrust and other forms of mistrust is. You suggested language that only a small percentage of the world would know, but you also had what it takes to recognize that you did that, go back, correct it, and explain it in a way that all of our audiences can understand. And that's actually exactly what communities are asking for.
Yes.
It's not that things wouldn't be, maybe really high tech or really immersive or really high level. It's that we would be able to access it and understand it, no matter how great or how far or how Harvard it might be, that the communities would still be able to connect to it. And so first, I want to say thank you for modeling that really well for us. That's spectacular. But that also is who you are, and that's who you've been in your life. It seems like there's a lot of tension in the work you guys do, not necessarily between each other, but it's like between you and the IRB. Steve, it's like you might go to a community and there's some tension. Steve, you might have some colleagues and there's some tension because they maybe want to take a different path, a different route. Maybe they don't have the sensitivity toward communities that you might want. I'm curious, before we get into some of the science around cancer care, what do you do with this tension? What do you do? What does it make you feel? Does it discourage you about tomorrow? Does it encourage you? Does it inspire you? Tell me a little bit about that.
Well, Steve, maybe you can riff off of me when you hear.
I will definitely riff off of you.
because but that's the whole point of being in the middle of the mess. I mean, it is about I came to the national level now because I wanted to give voice to 62 million Latinos. Yeah, I represent all 62 million. But, the point being was the voice has not been heard. It has not been public. It has not been engaged at this very high level. And so I wanted to be sure that our voice was there, because the point was to be at those tables where we really could start to impact impact policy or rules and regs, et cetera, et cetera. Point in, if I hadn't been at that table at that first IRB, we would have not had a Spanish language website because nobody would have even given it a thought. And now that all of us in its 6 years has now enrolled 84,000 Latinos. Half of them are immigrant and half of them are U.S. born. And they are from every state except for some reason Massachusetts. At least that was the last I heard. So that means Latinos have shown up in every single state in this country to enroll in all of us. So to your point, Ruquan, we do care. We want to know. Talk to us so we understand it, and then we can give our consent. I saw this all the time when we did community engagement, because once again, the journalist in me said, people need to know before they can say yes or no. And so we have to educate the community around issues of cancer. So I created a bingo game. You took out the numbers and you put in the facts, and then we would pull together maybe groups of 25. There's safety in numbers, right? And people would feel more comfortable. And we played breast bingo, colorectal bingo, cervical bingo. We worked with LLS, the Leukemia Society, on blood bingo. And the particularly women who showed up for most of this, they were hungry for information. We saw it. And the good thing about that, Stephen, too, was that what we saw was a kind of the peer support and the peer pressure that emerged at those tables, as opposed to being talked at by an academic researcher. It was people talking to people in their language. And I remember one time, and because I'd always ask the promotores to check in with me and tell me what's going on, how's it going? And she said, one of the women said, I'm too embarrassed to show my breasts. And the other woman said to her, better embarrassed than dead. How much more blunt could you get? And how much, and yet that held all of that embrace. And it was giving women permission to share with each other their fears, their concerns, their lack of knowledge, and somebody else helping them. Same thing with the cervical bingo. A woman said, my husband won't let me go and get a screening. This is where you start to see the social and cultural beliefs that get in the way. So another woman said to her, it's your body. You go take care of it. Permission, support, and this is why you need community to be there. And Ruquan, community is so critical in all of our communities. So I would say, in the faith-based community, during COVID, one of my colleagues out of Maryland was using beauty salons and barbershops to talk about COVID and to get people moved into testing and screening. It's possible if you respect community. And about that tension, I roll with it. I did, as of one of the first Latinas in television back in 1970, I rolled with it because it was me deciding I'm here for a purpose. I've got some work to do, and I'm not going to move out of it because you say I should. you know? So I sort of became, as the reputation went, so maybe Dr. Martin Luther King would appreciate me, good but trouble.
I absolutely love that.
And so do
Well,
I.
and Ysabel, tension exists.
Yeah.
Tension exists everywhere.
Yeah.
The problem isn't necessarily the tension. The problem is not acknowledging it and understanding what goes into the tension. So
Mhm.
there's an expression that I've always used, and I think Ysabel, as a journalist, will understand this, and that is move to friction. Move to
Mhm.
where the problem is and try
Mhm.
to understand. Maybe you can solve it, maybe you can't, but unless you understand and ask the questions, you'll never know. Doctors do that all the time when faced with a patient problem, move to friction. The other thing that you said that I think is really important, and we learned this a lot during COVID, was that you absolutely to solve the underlying problem that you have to understand the circumstances that people live in. And you have to understand what they bring to the table. So when we started to have conversations with different communities about the COVID vaccine, the African American community was concerned that, you're experimenting on me. Often that was what we heard.
Mhm.
And you're not engaging me about what that means, and you're not
Mhm.
telling me everything I need to know. That was a thought. And of course, there's a history behind that. With the Latino community, it was often maybe some of that, but it was also, this is what my family looks like. This is who lives with me. This is what's important to me, my church, my community,
My
etc.
job, my family.
And I don't have a CVS around the corner from me. So what am I going to do to actually get access to testing, et cetera? So it's true of cancer care as well. And it's one of the concerns I have about cancer screening and the work we're doing is what's next after we develop something that's easy and accessible for folks? Because we can't just drop it there.
Well, here's something interesting about that. Well, you possibly saw the FDA approved self-testing in clinics for cervical cancer. I think that's very cool,
Yep.
because it goes back to what that woman said. My husband won't let me for fear that she was going to go to a clinic and be examined by a male doctor. And so this kind of patient engagement as part of their own care actually I think it exposes them more to being in charge, to being in control instead of giving themselves up to a doctor, which I'm sure Steve frustrates you sometimes when people just kind of wait and say, okay, doc, tell me how to save myself, right? Or you're going to save me, doc, right? That sort of stuff. And so this, I think, is really critical for patients to feel that they have some agency in this issue. And the more we have these tools, simple tools, inexpensive tools that are accessible around the corner at the Walmart or the CVS or whatever, but you still have to educate people that they're there. We're seeing a bigger, there's kind of a flat line for colorectal cancer amongst many groups, and it's like less than 50% for most groups in terms of screening. And colorectal kind of flatlined, especially during COVID. Everything went sideways during
Right.
COVID. But one of the things they did see was it flattened, but it stayed flattened instead of went down because there was an uptick in the fit, using the fit kit, the newest colorectal self screening kit, and and who was doing it? It was in Black and Latino communities mostly, and some Asian uptick. But once again, to me, it's about instructions, and I'm a big believer of community health workers, and AKA promotoras, because I think they're the bridge. They're the bridge between the community and systems, and we really need to invest in that group. And the president recognized that with the Cures Act by putting out big bunch of change and promoting the development of community healthcare workforce. Here in California, the governor invested in that as well. And now community healthcare workers are reimbursable through Medicaid, Medicare. There's so many of these insurance programs, but the
Cal,
state,
right.
right? The state insurance program. So a clinic can hire a community health worker and get reimbursed because they wouldn't before. There was no funding mechanism. So many states in these public health care clinics who could really utilize this bridge don't know how to pay for it. But here's my fear, Steve, that they will hire them and turn them into robots like themselves. So in other words, they do not utilize them for the right reason. You're outward facing. We're like the visiting nurse, right? You're
Yep.
going out in community. You're going to go door by door. You're going to introduce our services. You're going to bring us new patients who don't have a medical home. You're going to talk about screenings. Are you up to speed on all those screenings? Oh, the seniority, your husband hasn't done it. Okay, let me talk to you. Just different stuff in ways. And with AI around the corner, they need more guidance than not. Excuse me. It's been here forever. Pero it's now at this very high level, and in using our medical records and so on. We have to be knowledgeable. We have to get engaged. We have to put limits if we want on the use of our data. But we have to know we have the right to put limits on the use of our data. So what is it? Education, education, education.
Leading to empowerment. That because I think you made a really good point about the use of fit in communities during COVID and post-COVID, and there's a lesson to be learned there. So what information do people need and want, and how do we provide them with the empowerment that's important to them? And that's something that you can only learn by talking to people.
And I'm going to challenge you, Steve. I hope you don't mind.
Never.
I have come to not like the word empowerment. When I started in 2000 and built these small agencies, I love the idea of empowering. But what I came to see of empowerment to me was that it really is a patriarchal kind of a permission. Hey, we're going to give you power to do or to be or to whatever. So I remove that kind of word from my vocabulary and actually saying I'm powering up. We're powering up the community. You have the power. You just don't use it, right?
You do.
I mean, who else is going to make that individual decision but you? That's power. So let's use it in your best possible way. Power up the community, activate them.
I am ready to use power up, because that's exactly what I mean. It is, you said this about when I took care of patients. I actually didn't like it when someone said, "Whatever you say, doc." That was not a good partnership between a doctor and a patient. And so having a person powered up to challenge and to ask the questions that they need to ask to get the best care possible was the best situation for me taking care of people. So I absolutely love it.
You guys are definitely teaching me and teaching us so much about the way that these things are working right now, what's happening in these communities. You guys are kind of giving us an inside look at what's going on in communities, what's going on as it pertains to cancer care and medical mistrust. My question is really connected to the conversation that's already being had. I want to know what the current state of play is as it relates to cancer screening in particular. From your vantage point, tell me where you think it's working. Tell me where you think there are still challenges. Now, don't feel obliged to repeat any of the things that you've already shared about some of those challenges and where it's working, but kind of keep going on that line about agency, about powering up. Are those some of the things that need to happen for cancer screening to improve? Is cancer screening already where it needs to be? What are your thoughts about that?
Well, I'm going to, if you don't mind, I'm going to take a half a minute and give people actually a little bit of history around screenings. And Steve, you're probably a better man than I on this stuff, but I'm going to throw it in because I was thinking about it. How long have we had all of these screenings, and how far have we actually come with these screenings, right? So the Pap smear actually was introduced in the 1940s, became a standard in the 1950s. Mammography became widely used in 1970 for breast cancer screening. Before the FIT test, there was something called the FOBT, which was introduced in the 1960s for colorectal screening, and as I said, and then was followed by the colonoscopy in 1970 and 1980. Well, we know that that FIT test is much cheaper and less invasive than a colonoscopy, and most people would prefer it, and it really is becoming, I think, Steve, more of a standard for early intervention and being able to remove the more at risk from those who, over a period of time, you establish a standard and they're doing okay. So they can keep taking the FIT. But this is really cool. The PSA test for prostate was in the 1980s, but there's been a little bit of controversy about, does it work? How well does it work? What kinds of tensions does it create for men? And we know that this is an area, Ruquan, where the Black community, really, the men really, really, really need to get on top of this. There's some genetics related to it, et cetera, biology, et cetera. But we really need to bring them along. And I have some colleagues here in the Bay Area who have a African-American Black support group and are really focused around prostate cancer because it's really critical. Let me see. Did I hit all of the tests? Prostate,
lung cancer.
Lung cancer. Thank you. Yeah. So we have these low dose CT scans. I don't know when this has been evolving for the longest time. So you pick it up, Steve.
Yeah. First it was chest X-ray,
Okay.
80s and 90s, but really a lot of difficulty proving that an annual chest X-ray improved outcome. And so ultimately it was a very large low dose CT scan in a high risk population, a certain amount of smoking per person that really elevated that risk, and found that it improved survival to have an annual checkup with a low dose CT scan. So that has become approved by the U.S. Preventive Health Task Force as a mode. The problem, of course, is the uptake and the access to a scanner or access to a colonoscopy.
And the cost.
And the cost. And you're right. And FIT is a lot more enjoyable than a colonoscopy, that's for sure. And who wants to lie down for a CT scan and travel to the hospital to get that if you don't think that it's that you have access to it or don't have insurance, et cetera.
So, sometimes way out of your way to get to any.
Way out of your way, right.
Way out of your way.
It's one of the reasons that we're developing a blood-based approach, because almost everybody, even in communities that are far away from hospitals, can get access to blood draw or can have a community worker draw blood, et cetera. The question that I'd have, Ysabel, is as we develop new ways to screen, and I think it's revolutionary to screen blood for cancers, for goodness sake. I know we have PSA, but to actually measure the genetic material of cancers in blood, how do we have a conversation with communities that might not trust kind of newer things coming out and the science behind it to ensure that they have the information they need to make the decisions that are right for them, and that they have the belief and that there's truth behind the fact that it's representative of them, their families, their lives, their communities?
Yeah. Well, I think once again, it goes back to the education and the early intervention. And so that is, having a community health worker on your right wrist. And that is that they're there to introduce communities to these issues, to explain to them in the most clear, simple ways about how these new kinds of tests will be coming on the market. But those are also systems issues, Steve. If we don't solve the systems issues, we can tell people all we want about these great new fantastic multi-cancer tests, and they're not going to get them. They're not going to be able to afford them. The Grail one, which is Galeri, that's like $900. And I had a colleague at UCSF who told me, and he's an oncologist, and he said plain old screening does better than most of this right now. It's not all proven. I mean, there's too many false positives, or could be. There's still a lot along this mission. And I think it's great, though. It's the least invasive. It's simple. It's easy. But once again, we're stuck in this barrier for low-income people to have access, to have awareness, to be able to afford it. And it's got to be built into the system through Medi-Cal, Medicaid, Medicare. In fact, Congress is considering MCED, which is multi-cancer.
Yep.
I wrote a letter supporting it, despite my misgivings about the quality of the testing at this stage. But everybody's in the business. So once again, Ruquan, we better be there at the table to be able to say, whoa, folks, okay, you got this, you're working on it, you're moving towards it. How does it impact my community? Are they going to have access? What costs are you going to charge? All of that. Where is it in the rules and regs? And in, whoever has to determine whether, I don't know who, Steve, you could tell me, who is going to determine payment structures? Is it CMS?
Yeah, typically it would start with CMS for diagnostic tests. Now, there isn't a great track record there, and ultimately the private
Mm.
payers will make a determination around that, often based upon how much it costs to run the test. But let me go back to this issue of access, because I think we don't talk enough about it, and you hit the nail on the head. The access issue isn't, can I get my blood drawn? Because, well, it might be in part, but a lot of people are able to get their blood drawn, and a lot of inexpensive blood tests can be done that really would help people. But it's the cost associated with that cancer screening test that's a huge issue. And one of the things that we started to do from the very early stages of our company is say, one of the hallmarks of a screen is an inexpensive test that's accessible to all. That's an underlying principle for screening tests. We absolutely need to design and build our test to be inexpensive. Think about out of pocket or so inexpensive that even if insurance didn't pay for it, you could at least screen people and then do the appropriate tests afterward. So there's ultimately businesses decide this when they commercialize, and people have to invest and get a return on their investment, et cetera. That system has worked to get things into people's hands to take care of folks, but a lot of people have left behind. So I would say it's the entrepreneurs and the doctors in the world that have to sort of jump in and say, hey, we have to be cognizant of cost, because cancer screening can't just be for people who have a lot of money. That is, in fact, the people who need it the most and have the worst outcomes, typically because cancers are found late, actually need this the most. And it's an imperative.
And so when you start talking about where they started all of these screenings these many, many decades ago, and you look at the status for low income and vulnerable populations, it's like nothing's changed.
Right.
You know, they're lucky if they get, but they're not getting advanced care. I'm over here fighting for the opportunity for women who have cancer, a history of cancer in the family, can now be moved if they, you know, if we use a tool, check it out, determine they need to get a genetic test. That's not even in the rules and regs. We went through 16 months with one federally qualified healthcare system for them to discover the protocols, the payers, and the policies around within their system. And this is where poor people go, federally qualified healthcare systems. And so if they're not ready for this, how can, you know, where do people go who have these biggest challenges?
Maybe that's where we start.
Okay.
In those systems, because you saw, as you said before, it was beautifully said, Ysabel, if you solve it there, if you address all the problems there, then the people who go to concierge docs and have insurance, et cetera, it's pretty easy for them anyway.
Right.
But you solved it for the situations like the federally health, you know, the qualified local healthcare, community healthcare. You probably solve a lot of problems. I would love to continue this conversation with you.
Let me share a story with you because it kind of encompasses how I've been really mapping this out in my brain. And that is, I did go to the 2022 announcement in the White House for the ramp up on the Moonshot, you know, reduce cancer by 50% in 25 years, you know, and I heard a really great vision and a lot of talk of investment into research. And so I walked up to the president's advisor afterwards and I said, you need community voices at the table. I walked up to HHS Secretary Javier Becerra. I said, you need to have community-based organizations putting their, you know, CHWs out there to help you with this. I walked up to Ned Sharpless, who was then the director of the National Cancer Institute. And I said to him, the community needs navigators. You're not going to get this done. I said, there are no macro solutions, only micro approaches, community by community by community. And so, you know, I kept telling that you need voices at the table. So that's when the president turned around and nominated me or appointed me to the National Cancer Advisory Board. So, Ruquan, there I am again in the midst of, you know, and I'm saying, what can I do here? You know, what can I do here? There's a lot of smart people at that table. They're from medical centers, you know, they're the cream of the cream and so on and so forth. But I've already started to try to figure out how to make trouble, because I am saying to them, if the people who are most under-researched and get the least of the $5+ billion that the National Cancer Institute has, how are we actually addressing equity? How are we actually getting to the basic issues that if we solve those, we will have lifted everybody's boats? Isn't that what they say?
Exactly.
Yeah.
Exactly.
Well, you've given us a phenomenal opportunity to be powered up
Good.
and encouraged to take this approach and to continue to face that tension and rest at that tension. It seems like through your story and experience, you confronting that tension and resting in it, whether it be being at the meeting with the president and his advisors and choosing to go up to each advisor individually and confront them, or whether it be being in the midst of being a cancer patient and confronting that diagnosis with a question to God and confronting God even and confronting the doctors. It seems that you've gotten a lot out of that. And so I'm excited about Steve's vision in the private sphere in terms of making impact through a health company like this. And Steve, my question to you is, when it comes to keeping the cost low for products like the one that your company is building, what challenges do you see lying ahead? And how do you imagine being able to overcome that?
Well, first of all, let me just say the investors that have invested in our company have very much embraced the concept of a low-cost screening test. That resonates with people.
Right.
And they recognize that screening tests can't cost a lot of money. And that's, I mean, there's a lot of folks who have insurance who have big out of pockets who can't afford big bills for screening and will probably forego them. So it's a pretty significant problem we're facing. So that's the first thing I'll say. The big challenge ultimately is for diagnostics and cancer screening is going through the system and getting it ultimately to the point where it's approved by all the necessary bodies. And it gets back to the conversation we had before about government, academia, et cetera, the medical system. There are entrenched interests, and there are misaligned incentives. And we need to align them better. So the big challenge for me is, how do I make sure I align the incentives, most importantly of people, consumers, patients, however you want to refer to folks, with those of the payers, those of the regulators, those of, the providers. How do we align those interests so that everyone says, yeah, this is a great idea and this will help solve a problem? I can assure you we've met no person who said, we don't want equitable, fair access to cancer screening. The problem is everyone comes at it from their own different direction. Payers want to save money, including CMS. They don't want to spend too much on X, Y, and Z. Patients just want to live longer and have a good quality of life and stay healthy. Providers have their own sets of pressures. So you can see that it comes from multiple different directions. So that's the big challenge for us. How do we align all those, knowing that our North Star is an inexpensive cancer screening test for everyone?
Actually, I like that, but I think our North Star is we want a healthy population. We don't want a sick population, right? I mean, that's the whole point of those early screenings. So we can intervene early, keep people more healthy, help them live instead of die at the fourth stage, even if they're using advanced technology or even if they're using all of the latest kinds of drugs and so on and so forth, if they can afford it, right? If they can get access. And so I am all about prevention and early intervention. And I think, Steve, with tests like that, they can also provide that. But that's not as you mentioned earlier, that's not commercial, but when you think about it, multiplied one person, about how many, 367 million people in this country at one point in time, they could all use one of those tests, right? Possibly if we know by genetics or biology, or we know that lifestyle or environment is driving, these issues. And have a better, I think a better understanding of that from one community to another, from the African-American community, from the Latino community, Asian community. Do you know that it wasn't until 1992 that they actually started gathering or disaggregating Latino data from non-Hispanic whites? So there's whole periods of time when they weren't even separating them out. And they are different. We are not a monolith as Latinos. We're 62 million people. And, you know, we are, some of us eat salsa and some of us dance salsa. And then we, all of these things in between. So to try to say you're all alike and you only need one tool and, you know, we treat you all the same. Well, that's the rest of the world too. You know, it is that one by one patient. Steve, I'm sure that you didn't, you know, you had some basics, but they were one patient at a time.
One patient at a time. And we have learned that, Ysabel, what you just said, and I think it's so important. I want to emphasize it, and that is that there may be underlying genetic similarities by race and ethnicity. In fact, we've detected some of that in our test. However, environment, if you emigrated from one country to another, we know that it takes a generation to assume the risk of cancer of your adopted country. And so you have to believe that there's an environmental component of it. Do you live near power plants? I mean, there's so many things that go into this that there's not a one size fits all. And that's one thing I learned as a cancer doctor. You have the component of the genetics and background, et cetera, and where people live, but you also have the community there. And all those things go into the decisions and the approach that you need to take. This is no different. This is actually the same. It's complicated, but it's doable. And you're right. It's a person and a community at a time.
I'd like to know what's at stake. What happens if we do not find effective ways to price products like this? What happens if we don't find effective ways to ensure that community is a part of these processes and these cancer care development processes? What's at stake? What do we lose?
Well, we lose, I think, a healthy, productive society. When you break down our individual communities, you take the Latino community as a economic backbone of the country. Their gross domestic product is something like $3.2 trillion, the size of the fifth largest country in the globe. They're an economic backbone of this country, and if they're not healthy, you know, if they have to worry about being able to pay for their care, we're going to run out of them a lot sooner. There are a lot of Latinos in this country who are I think it's almost like 40% of Latinos in this country are under the age of 20.
Yeah.
So that's your future workforce.
Yep.
And that's your future payer for those drugs. It's the same thing in the Black community and the Asian community, which is a growing population. You know, these are your economic dependents. The non-Hispanic white community is going to depend on the rest of us. So they want to make sure we're healthy. So how are they going to help it? By helping drive policies, helping talk to their congresspeople, helping talk, whatever it takes for them to join us so that we can all get healthy together.
You know, this is so important. And when you think away the way the system works, not that the system doesn't need to be changed, but we're going to need healthy people to pay taxes to support Medicare and Medicaid and all the things that we pay for as a government. But the retirement funds of people who work and have 403Bs and 401Ks, they go into funding startups like our company. I mean, people's real retirement dollars go into these things. And it's not just a money issue, right? Because at the end of the day, we need innovation. We need people to come to the table and to develop new therapies and new approaches. And we need to make sure that we construct a system so that there's appropriate oversight and the appropriate incentives, but that we don't lose the ability to innovate and to help people. We are in an incredible period of time in terms of the biological approaches to medical problems, health problems. And to Ysabel's point, we need to now shift away from a sick care system to a well care system. And the way we do that is with preemption and prevention. And we need to make sure we invest there, but we also need to make sure that we don't create the disincentives for really smart people and really good people to go out and develop these approaches to help folks. And we are at risk for that. So we need to figure out the best way to approach that. And I'm not one of these people that says, you know, let the entrepreneurs do anything they want. I am totally against that. There has to be the appropriate oversight. But if we incent the private sector to help us with value-based care and with approaches to reduce the costs, I'm pretty convinced, like we saw with COVID vaccines, it will happen.
Let me ask you this, Steve. I'm gonna throw you one. I think because we've been talking about it in AI as well, and we've developed a patient bill of rights out of the Light Collective. We've been working on that for a while now. But one of the things that I said was, when we talk about shared benefit, what the heck does that mean? And when you tell a patient, okay, well, we're going to use your data to come up with these big ideas and solve these big problems and make this big money, and they're saying, what's in it for me? So one of the things that I propose, Steve, you calculated from your point of view in your company, but was that especially if you get government incentives, what is that? Taxpayer dollars, right? So how about for every dollar, and could be super wrong on every $100 that you get from some incentive or something, or from the data of a patient or et cetera, wherever those come from, that you create a people fund in your company. And that people fund gets 50 cents or it gets something from, you can figure out the formulation. But it's kind of we're all in this together. And what we learn and what we grow and what we build, you've invested in. And so what we do is, I can't pay you back $1.50 for your data, because I'm not sure who you are. It's supposed to be de-identified, right? Or however you handle it. Maybe clinical trials, you do know. But the point is, you put it back in and then you say, now, how do we decide what do we do with this pot of money? Oh, we live in this geographic area, or we're taking from this group of people. How do we incent back? Maybe we help them even get a low cost or no cost test, or we pay for some of the drugs they need that they can't afford. So we help to reduce the cost. It's just something, but it's to me, it's kind of magical. And it's kind of people saying, wow, look at it. There's something back for me. No, not specifically, but it helps my family, my community. And I'm part of this discovery and this science.
Ysabel, this is exactly what I meant by creating the incentives to help solve problems. Because, and I testified before a commission recently about this, the economic and financial reimbursement framework and the regulatory framework are not designed to do exactly what you said. So let's include you in the research if you want to. Here's why we think it's important. And let's make sure that when we go to the real world setting, we're actually following up and understanding how it affects communities that we didn't necessarily look at in our clinical studies. And then in exchange for developing a product that gets a certain level of reimbursement, let's give back. Let's set aside, as you say, I am pretty sure that many companies would take the federal government up on that proposition. Because right now, all the pressure is in the opposite direction. And that's good. There's tension there. Move to friction. And we can help solve these problems. I am convinced that what you just said will have a huge impact and is the right way to proceed.
Cool. We have to start the movement.
Well, let's do it. Absolutely. I'm with you.
You model then. You started.
Okay. You bet. Absolutely. No question about it.
Ruquan,
before we go, you guys, thank you for all of the information, wisdom, insight, innovation, the ideas that you guys are both sharing, and the way that you guys are collaborating has also been phenomenal to see. Ysabel, tell me, what do you want the 40%, those young Latino kids in this country and in our world, what do you want them to know from you?
Actually, I want all young kids, all of those 40%, those 30%, because they are our future. And, when we talk about powering up, we need for them to power up and step up and be sure that they're engaged, that they're now the eyes, the ears, and the survivorship of the community. We depend on the resilience of our young people. What are those, alpha A's these days, or Gen
They
Xers?
are. Yep. Yeah.
Well, I'm going to give Ruquan, he's in this group. He's now the new leaders, right? They're the new leaders, and we need you to step up, because what we need you to remind the community is they're important. Their voices are critical. their actions can make a difference, and their vote. I won't go there too far, but really, you're the messenger, and you just have to light them up. You have to activate them and move them from that sense of I have no power to, in fact, yes, you do. And don't give it up to anybody. In fact, your data is your power, right? So, I want these kids, I want all of you to engage, because I think there's so many smart young kids out there. You all have a different way of looking at the world, I think, in terms of being engaged, of caring about issues. Although maybe that's also genetic. It happens from generation to generation to generation. We've seen it. So, but I just put a lot of faith in our younger population, but I also put a lot of obligation and responsibility on you guys, because I think we've all been doing our work as we go, but we can't always keep doing it. So we need someone to step up, and I think young people have the opportunities, the talent, and the energy to get it done. Just move it forward.
Well, absolutely. You serve as a representative of your community, and I serve as a representative of Gen Z and Gen Alpha. So I'm here to say, on behalf of us, we are absolutely accepting that call, and we're so happy too that you guys are passing us the torch and showing us the way. So thank you, Steve, for the work you do. Ysabel, thank you for the work that you have done, are doing, and will do. Thank you for sharing this time with us, and we are excited to keep collaborating with you.
Well, thank you for asking. And it was a pleasure to spend time with you, Steve.
Ysabel, I feel the same way. And Ruquan, thank you. It's really been a pleasure. I can't wait to move forward and power up with you, Ysabel.
Oh, cool. And Ruquan, he's part of it now.
Oh, for sure, Ruquan. Yeah.
All right. Bye.
Bye-bye.